Hi, this is Tom Oding at the University of Iowa. I'm going to show you an interesting case where we had vitreous loss just a bit ago. You can see that the nuclear material is coming out nicely. We had a perfect rhexis that was round and centered. Pieces of material are coming out okay. This is a resident that was just getting used to using the second hand, was having a little bit of trouble using the Drysdale together in the crowded chamber with the needle. But you can see that the nuclear material is coming out. Chamber's a little bit floppy here. The iris is moving around a little bit. But we really didn't have any suspicion of any trouble to this point. But I want you to watch carefully because you'll see eventually that there is an area where the posterior capsule is damaged. You can begin to see it now just above the phaco needle. Of course, we didn't notice it at this point. We're just finishing up the last little bit. She's trying to keep protected there. Lost the chamber just a second there. But we really didn't notice the trouble until the very end here where we come out with both instruments. And then we notice this hole in the posterior capsule and it begins to get bigger and bigger. But we also wondered a bit as to how this hole came about. So we went back and looked at the tape, and you can see that she's having trouble getting the Drysdale and the needle organized. And right there, she smacks the posterior capsule. Watch as the Drysdale in slow motion gets stuck a little bit on the needle, and she really whips that posterior capsule. And I think that's the reason that we have this posterior capsular tear. So now we've made an additional incision for the anterior vitrector, and initially we've got the cut rate very high at about 800 with a vacuum of about 150 so that we can remove the vitreous which is in this area. So we're trying to beat the vitreous back down to the area of the posterior capsule. We're adding some Viscoat here to stabilize the chamber as we begin to remove some cortical material. We're using a 23 gauge Cortex extractor here. With no infusion of fluid, we're just going in and we're grabbing a hold of the cortical material, and with a dry technique we're just removing the cortical material and placing it in the center, where later we'll remove it with the anterior vitrectomy instruments as shown here. Now we take the cut rate way down to about 200 or so that we can more easily get this cortical material out of there. Now here we're going to show an alternative technique where you turn the cutter off and engage the cortical material and then bring it to the center as shown here, and then you can engage the cutter again in the center. So this is a nice technique where you turn off the cutter, go out to the periphery, a little bit of vacuum, pull it to the center, and then turn the cutter back on. You have the cutter on in the center because that's an area where you think there's likely to be some vitreous. A little bit more is left in the subincisional area. And again, we're turning the cut rate lower for the removal of the cortical material. You also turn it lower for removal of OVD. So we've almost got all the material. We're going to add some more Viscoat here because we're going to go and get that residual material with the Cortex extractor cannula. And we're going to pull it to the center and once again remove the cortical material with the anterior vitrectomy instruments. Now we're going to place an MA50 lens in the sulcus, and because we have a perfect anterior capsulotomy, we're going to place the optic posterior so that the optic's in the bag and the haptics are in the sulcus. You can see we've taken great care to make sure that the lens is right side up. To twist it around a bit in order to do that. We're going to use a Kugeln hook here to place this lens in the sulcus. So now it's nicely in the sulcus, but we're going to push back posteriorly such that the optic becomes entrapped in the anterior capsule. So it's captured and the optic is in the bag and the haptics are in the sulcus. We're going to remove the residual OVD, turning the cut rate down. We've sutured the main incision, we've sutured the larger paracentesis, the lens is centered, and we're in good shape. This is Tom Moody, University of Iowa. Thank you very much.